Chat is only for the panelist.
Okay. So all attendees can put their question in a question answer box. Good afternoon, ma'am.
Good afternoon, ma'am.
Dr. Nidhi?
Yes, ma'am.
We can start. Madam has joined.
Okay, ma'am. I will start my screen sharing. Is my screen visible to all?
It is, yeah.
Okay. Thank you, ma'am. We will be starting.
Very good afternoon to all the delegates and the dignitaries. I am Dr. Pratibha Roy, Assistant Professor in Department of Obstetrics Gynaecology at HEMSER. I welcome all the delegates and the dignitaries in this online CME on cervical cancer prevention, a collaborative commitment. As we all know that this day celebration was started 3 years back in 2020 by WHO with the aim of eliminate the carcinoma cervix by the year 2030. So to start with, I would like to welcome our Dean Ma'am, Dr. Professor Midhu Judeda, our Dr. Leela Dugumarty, President ISCCP, Dr. Vijay Jatsi, Patron ISCCP, Dr. Musharraf Hussain, our Medical Superintendent at HEMSER, Dr. Aruna Nigam Ma'am, our HOD and Organizing Chairperson of CME, and Dr. Nidhi Gupta Ma'am, Associate Professor and Organizing Secretary at of this CME. So now I would like to request our department, Dr. Aruna Nigam Ma'am, to deliver a welcome address.
Thank you, Dr. Pratibha. So in today's CME, which is on cervical cancer prevention, a collective commitment. It has been done on the occasion of Cervical Cancer Elimination Day celebration. Respected Dean Ma'am, Dr. Leela Dugumarty, ISCCP President, Dr. Vijay Jutchi, ISCCP Patron, Dr. Musharraf Hussain, MS HIMSER, and other dignitaries who have joined, and all the delegates. A warm welcome to this pivotal CME on cervical cancer prevention, uniting MBBS students, doctors, nurses, and Ayush practitioners. As healthcare torchbearers, your presence signifies a collective commitment to combating this silent yet critical health concern. Coming together is a beginning, and this unique CME, where all the frontiers of health have been brought together to mark the 3rd year of our commitment towards elimination of cervical cancer. Today's session aims to equip us with comprehensive insights, fostering collaborative approaches in early detection and prevention of cervical cancer. Together, let's delve into knowledge exchange, embrace holistic perspectives, and forge a united front against cervical carcinoma. Your dedication to learning and sharing will undoubtedly impact the countries. Thank you for joining this imperative dialogue. And now I hand over the mic back to Dr. Pratibha for the invitation to rest of the dignitaries. Your mic is off, Dr. Pratibha.
Thank you so much, ma'am. Now we request Dr. Leela Dugumarty to say a few words. She is very well known for her dedication and contribution in preventive oncology. Ma'am, please, over to you, ma'am.
Yeah, good afternoon, esteemed faculty and the delegates who have joined for this wonderful webinar being planned and executed by Dr. Aruna Nigam and Dr. Nidhi Gupta. I welcome you all as President of Indian Society of Colposcopy and Cervical Pathology. So actually we are at World Congress of International Federation at Colombia. We had discussion about the global call for elimination yesterday. So what I understand is we are no way behind in having the systems in place. We do have vaccination, we do have several screening tests, Of course, majority in government and some are in private. And we all have committed gynecologists, colposcopists, and Dr. Aruna Nigam said, like many healthcare workers are being trained. So I think the next step for us is, in addition to advocacy, we all need to move into action to reach our goals in the remaining 7 years. With this, I thank Dr. Aruna Nigam for organizing this wonderful webinar for a cause on the 3rd anniversary of Global Call for Cervical Cancer Elimination. I wish you her all the best, not only for the workshop, but for everything. Then I also like all the participants to understand the cause and to take a lead to screen their own women who come to their clinics. Thank you very much.
Thank you so much, ma'am, for such wonderful words. Now I invite Dr. Vijay Jyoti for her enlightening words. She is a dexterous surgeon and an astounding academician. Please, ma'am, over to you, ma'am.
Thank you, Nidhi and Dr. Aruna, for your enthusiasm. I have no words to describe. You finish one CME, go next. But anyway, this is a very appropriate time to celebrate our 3rd anniversary for the elimination. I think Dr. Leela has said everything, and we have everything, but we lack advocacy. As an individual, I think all of us can make a difference till the government will come forth and advertise it on all the channels. I still see a hope because of this HPV vaccine, which has been launched, the Indian one. I think at the prime time we are having information regarding HPV. I think we are not lagging behind. Dr. Leela, you are very right. And with this, introduction of our own Indian vaccine, we should be able to at least achieve the goal. If not 30, maybe by 60, we should be able to eliminate cervical cancer. With these words, I thank Aruna, and I think they should continue with the CME so that more and more people are benefited with her, CME hours. Thank you, Nidhi, and thank you, Aruna.
Now I would like to request our dynamic Dean, ma'am, Professor Dr. Midhu Dedeja. She's an excellent leader, and under her guidance, HIMSR has flourished so much. And welcome, ma'am. Over to you, ma'am.
Thank you so much for inviting me for this very important and very essential CME, which is being held online by my very active department, for which I'm really very proud of, under the able leadership of Dr. Aruna Nigam and her very able faculty. Thank you so much for inviting me for that. And I would like to welcome on behalf of Hamdard Institute of Medical Sciences all the dignitaries, Dr. Leela and Dr. Vijay, and the participants who have spared their valuable time to be a part of this important CME, which is on a global cause and the concern raised by WHO with the aim to eliminate cervical cancer by 2030. This aspect was very much in the oblivion for quite some time, in spite of every woman dying, every one woman dying every 2 minutes. Like, that was a big concern, and in spite of that, it had not taken that kind of forefront. But I'm very happy that with the WHO, that under that crusade, my department of OBG, who is always a forerunner, is joined this crusade with active interest and participation. I would also like to welcome all the participants from healthcare, which are from different streams, including Ayush doctors, medical graduates, gynecologists, and even nurses and alternative medicine faculty who have spared their valuable time to be a part of this very important workshop, which is going to focus on basic preventive and cervical cancer training. I'm very sure by the end of the workshop, by the training of my very able faculty, all of you will feel very much confident in carrying on this crusade and be the torch bearer in performing the goal in action. That's what my other two esteemed speakers have said before, that advocacy phase is over. Now it is a phase of action. And I sincerely hope that with this webinar, my participants will feel very much confident in carrying on the crusade for early detection, which plays a very important role in treatment, because early detection leads to prevention, and this prevention has a very important role in leading to morbidity and morbidity due to cervical cancer. Thank you so much, and I really wish you all the best for this wonderful workshop. And with that, I hope that all of you will be very much valued at the and feel very much informed at the end of the workshop. Thank you so much.
Thank you, ma'am, for your encouraging words. Now I invite our energetic medical superintendent, sir, Dr. Musharraf Hussain, sir. And obviously, sir needs no introduction. He is an astute clinician, excellent surgeon, and a passionate teacher. Sir, welcome, sir. Over to you, sir.
Thank you so much. Thanks for the kind introduction. A very good afternoon to all of you. First of all, I would like to congratulate the whole department, Department of OBG, Hamdard Institute of Medical Science and Research, led by Professor Aruna Nigam, and Society of Colposcopy and Indian Society of Colposcopy and Cervical Pathology for organizing this short CME, that to an online platform. I think the choosing this platform is important, especially even in these days, is you can cover more audiences, more participants can be there, and you can spread awareness to a larger group of population. And I think that's a wonderful thought, and it's a very good initiative which has been taken by the department. And thank you so much for organizing all these things and spreading awareness. I am sure most of us will be benefited. Almost all cadre of healthcare worker has been included. That is the best part of this online CME which is being organized. So thank you so much and wish you all good luck.
Thank you so much, sir. Now I request Dr. Nidhi Gupta, Associate Professor at HIMSR, and our very young and enthusiastic Nidhi ma'am, to tell something about the course and to give the vote of thanks to our dignitaries.
Good afternoon, everyone. I am Dr. Nidhi Gupta, Associate Professor in the department. So I will be telling a basic information about our course, which we will be starting on
Dr.
basic
Nidhi,
preventive.
sorry to interrupt you. Ma'am, Dr. Midhu ma'am, I would like you to announce the release of this course.
Officially, I announce this course open, which is named as Basic Preventive Cervical Cancer Screening Course. And I wish you all good.
Thank you, ma'am. Dr. Nidhi, you can continue.
So as our course is already announced, so I will give some basic information on this basic preventive cervical screening course. It is recommended for actually all who are interested, but mainly undergraduate, MBBS students, intern, nurses, alternative medicine or paramedical students. Our aim is to develop the core knowledge and the necessary skills so that they can have enough knowledge about the screening of such a deadly cancer, that is cervical cancer. And the course duration of our 2 days training with the assessment, and maximum candidates we will be accommodating at one time will be 5. Who are interested can contact me. My phone number and mail ID is already given on the slide. After this basic information, and now I have been asked to propose a vote of thanks, and it's my privilege to have been asked this. So I, on the behalf of my OBG department, my all faculty, pay my heartily thanks to our respected Dean Ma'am, Dr. Mridu Dudeja, our ISCCP President, Dr. Leela Digumarti, ISCCP Patron, Dr. Vijay Jutsi, and our Medical Superintendent, Dr. Musharraf Hussain, for their valuable time in spite of their busy schedules. Thank you so much, all the dignitaries. In the end, I'm grateful to Dr. Aruna Nigam Ma'am for their proper guidance and constant support to make this CME possible. Thank you all. Now at the end, I will hand this platform again to Dr. Pratibha for the further proceedings in the CME.
Thank you.
Thank you.
Thank you so much, ma'am. this information. Now, heading towards the CME, I would first like to invite and welcome our respected chairpersons. First of all, Dr. Suhail Fatima. She is head of the Department School of Unani Medical Education, and numerous publication and awards has been named to her. And our next chairperson is Dr. Sabina Khan. She is Professor, Department of Pathology at HIMSR. He's an eminent pathologist, and numerous publications are named to her. And our next person is Dr. Ziba Shamim. She is a professor at in Department of Pathology at HIMSR. She is a distinguished pathologist. She also has numerous publications and awards attributed to her name. Now, our next chairperson is Dr. Manju Chugani. He is Dean and Head of Nursing at Rupaida College of Nursing. She is known for her enthusiasm for her work. And our next chairperson is Dr. Apita De. She is Associate Professor at HIMSR Hospital. She is a skillful surgeon with special interest in urogynecology. And our last but not the least, Dr. Shumida Samma ma'am. She is Associate Professor at HIMSR. Ma'am is a very humble, down-to-earth, and a very good clinician. And she has a special interest in fetal medicine and high-risk pregnancy. Now, I welcome all the chairpersons on behalf of Department of Obs and Gynae HIMSR. And I request our respected chairpersons to introduce our respected speakers.
Dr. Sohail Fatima, ma'am.
Yes, am I audible? Ji,
Yes,
Assalamu
yes.
alaikum wa rahmatullahi wa barakatuh, and very good afternoon to all present here. Thank you, Dr. Aruna Nigam, HOD OBG HIMSR, and Dr. Nidhi and their team, Dr. Musharraf, MS HASC Hospital, for inviting me here. Thank you so very much. It's my privilege to address you all on this occasion of collaborative event for cervical cancer prevention. The selection of the theme is very highly relevant and rightly goes and meets with the theme of 2022 and 24. That is, close the care gap through this CME. We have wonderful gathering today with culmination of Ayush and allopathic doctors. Here I would like to quote the verse of Al-Quran, which says about prevention of cervical cancer in Surah Al-Baqarah, ayat number 222. I quote, "They ask you concerning menstruation, say that is an adha or a harmful act for a husband to have a sexual intercourse with his wife while she is having her menses. Therefore, keep away from women during menses and go not to them till they are purified." Unquote. As we are now very well aware that the modern medical science says that it is a fact that sexual relation during menses may lead to several
You are not audible, ma'am.
I think Dr. Sohail's network is not okay. So Dr. Swati, who is a professor in the Department of Obs and Gynae at Lady Hardinge Medical College. And she is a renowned colposcopist and taking care of the oncology clinic there. So I will request her to start her lecture. Dr. Swati, please.
Yeah, a very good afternoon. Yeah, ma'am, am I audible?
Yeah, audible.
Am I audible?
Yes, yes, Dr. Swati, you are audible. Kindly start. Now you are not audible.
Okay, okay.
Yeah, audible, please.
Yes, ma'am, I'll start my presentation. So, it's an honor to
Your voice is cracking, Dr. Swati.
Dr. Swati, your network is not okay. So will you like to change your place?
Am I
If it,
audible, ma'am?
no, your voice is breaking a lot.
Okay. Yeah. So without further ado,
No, Dr. Swati, you are not audible. Dr. Swati, you are not audible. Dr. Nidhi?
Just let me start with my lecture.
Dr. Nidhi?
Yes, ma'am.
You can start, have my introduction. I can take a lecture. In the meantime, Dr. Pratibha can talk to Dr. Swati to change a place and we will have her second lecture.
Okay, Dr. Sabina, will you introduce ma'am, please, for the next lecture, as we are having problem in the first lecture.
Okay, a very good afternoon to all of you. First of all, I'd like to congratulate the Obs and Gynae Department of HIMSA for organizing this online CME on a very important topic. As a pathologist, we all understand the importance of the screening test, especially the PAP test and the screening program and the cervical cancer screening program, especially in a lower middle income country like us. And coming to the introduction of Dr. Aruna Nigam, who actually needs no introduction. She is an accomplished clinician, researcher, teacher, and mentor to so many others. And she's presently working as the head of the department at HIMSA. She established endoscopy unit in our hospital. She has more than 200 publications with the citations of more than 3,000. And she's editor-in-chief of Pan-Asian Journal of Obs and Gynae. She's also the national corresponding editor of Journal of Obs Gynae of India. She has many books to her credit, editor of 7 books. The latest are Drugs in Obs and Gynae, Recent Advances in Obs and Gynae, and on PPH. So she also has many awards to her credit, including the Women Scientists Award 2020 for special contribution. And she also started a very important educational website, which is a very good online learning platform in 2020 for the undergraduates, postgraduates, as well as for the consultants, which has the latest updates as well as the video lectures. So over to you, Dr. Aruna.
Thank you, Dr. Sabina, for such a nice introduction. And Dr. Sabina is very kind pathologist with us who bear all the things whichever we say, send and take care of all the pathologies of the gynae. So thank you. So as the first lecture, we are going to take after this lecture, which was on WHO cervical cancer elimination strategy. So HPV vaccination is a very important component of the WHO cervical cancer elimination strategy. And you can see on the one side of my slide, there is 90, 70, 90. And I'll keep on saying this to you that please remember this 90, 70, 90, and it will always be on my slide on one side, and you will understand what do we mean by 90, 70, 90. So till we have a problem of the internet, one woman died because it was a disturbance of 2 minutes. And 2 minutes, one woman is dying of cervical cancer. And each one is a tragedy, and we can prevent it. That was the motto which has been said in May 2018, call to action by WHO. And now, today we are gathered here to celebrate the Cervical Cancer Elimination Day of Action 2023, a 3rd anniversary, because we have to move towards the elimination of the cervical cancer by 2030, even if it is not possible because of the COVID for 3 years, where we have to divert all our things towards the COVID vaccination. But now we can do, maybe not 2030, maybe by 2035 or 2040, but we have to do it. And for this, we have to join our hands together. So with this, let me tell you what is this 90-70-90, which will be elaborated in great detail by Dr. Swati, WHO strategy to accelerate the elimination of cervical cancer. And what is this first 90, which I am going to take care of? That 90% of the girls, adolescent girls till the age of 14 years should be vaccinated against HPV, because that is the main cause of the cervical cancer. 70% of the women should be screened with a high performance test by 35 years, and if not, by 35 years of age. And 90% of the women identified with these cervical diseases should receive treatment for a precancerous lesion of the invasive cancer. That is the 90-70-90. And we together, by all integrated medicine, at least can take care of 90 and 70. And how we can do and why we should be doing, I'm going to elaborate upon, right? So today, the objective of my presentation is to talk on the role of HPV vaccine, why and how, the immunogenicity and the cross-reaction, the recommendations on the targeted group, that is why, dose, duration of protection, and the queries in various situations. So let me take each of the thing one by one. First, the role of vaccine. Why we want to vaccinate this target age group till the age of 26 years? That is the question which comes to our mind. If you can see this graph, let me take the highlighter. So if you see this graph of HPV infection, what you can see, between the age of 15 to 25, 28 years, the incidence of HPV infection is maximum when the female is becoming sexually active. And then continuous exposure to the HPV infection causes a cytological abnormalities, which is a time period for the appearance of the cytological abnormalities, and that is the pre-invasive lesion, for which we are taking care by the secondary prevention, and that is by the screening, by which Dr. Sabina, Dr. Zeba, and all the pathologists are helping us out. But as such, this can also be done by a VIA also. Then there is a development of the cancer where the specific role of the gynecologist occur, and we are trying to have an early detection and the treatment. But if you see this graph, how much high incidence of infection is there, and if you try to catch this time period, we are going to have a less pre-invasive lesion. And that is the purpose of the primary prevention, to have a multi-pronged approach, and we should be focusing on the HPV vaccination. And it is not that just a WHO said or some of the society said. No, it has been evidenced by the various trials like Future 1, Future 2, Petrica trial, Costa Rica trial, and many of the females, thousands of the young females, where it has been seen that vaccinating these young females is preventing the higher grade lesions. And that is the thing which we need to take care of by vaccination. And in 2019, the Lancet has clearly said in the systemic review and meta-analysis that compelling evidence of the substantial impact of HPV vaccination program on HPV vaccination and CIN2 among girls and women, and ongoing anogenital work diagnosis among girls, women, and boys and men have decreased enormously in these females who have been vaccinated. And we all know the Australia has achieved the target of vaccinating all the females, and now they are saying that they have proved that they are eliminated cancer from their country. So after these so many trials in 2019, WHO stamped that the HPV vaccine is absolutely safe, effective, and protects against the cervical cancer. And it has been approved by HPV and all the major societies. The question comes, how this vaccine is manufactured, and it is needed to be known by everyone. Remember, 90, 70, 90. I will today, my own sole purpose is to make you remember this 90, 70, 90. So all of us, we can together work on the elimination of the cervical cancer. So now coming to how this vaccine is manufactured in a brief. You see, if you vaccinate, you are not going to be infected with the this HPV virus, because here we are only using the virus-like particles which have been made by the recombinant DNA technology in the prokaryote system or a eukaryote system, and these then have been multiplied and have given the HPV virus-like particle, which causes the immunogenicity after injection, and this immunogenicity is 5 to 10 times more than what have a original infection, what the original infection does. So regarding the immunogenicity of this vaccine, it is highly immunogenic with a seroconversion rate of 93 to 100% following vaccination, and have a antibody levels of 1 to 4 logs higher concentration than the levels generated. These have demonstrated high efficacy lasting for at least 10 years and significantly higher antibody titer as compared to natural infections. It has an advantage of a cross protection. What do you mean by cross protection? Because you cannot use all the virus-like particles to make a vaccine. So like we have a bivalent vaccine, we have a quadrivalent vaccine against 4 virus, and now we have a nonavalent vaccine against 9 virus. But the cervical cancer is not only caused by these 9 viruses or these 4 viruses. There are other viruses also which are responsible for 10 to 20% of the cervical carcinomas. So this have a good cross reactivity for the other viruses also. So we can protect the patient or a woman with the other carcinogenic viruses also. So it has a cross reactivity against HPV 31 and 45 with bivalent HPV with a vaccine efficacy of 54% and 88% respectively against these viruses. Quadrivalent HPV virus reduce the incidence of HPV 31-45 by 40% and 43% respectively. So you see, this vaccine is very importantly protecting against the other carcinogenic virus also. So if you go back to literature, cervical cancer is caused in most of the cases by a HPV virus. And this HPV virus all over the world most commonly is HPV 16 and 18. That means 70% of the cervical carcinoma is caused by HPV 16 and 18 all over the world. Remember this, all over the world. It is not only India. That's why the universal vaccine at all the places is effective. Right? So there are 6 licensed HPV vaccine, which we need to know. There are 3 bivalent, that means against 16 and 18, out of which Cervarix is available in India. There are 2 quadrivalent vaccines, that is against 6, 11, 16 and 18. 6 and 11 are responsible for the wart, and 16 and 18 are responsible for the cervical carcinoma. So these are available with us in the form of Cervavac and Gardasil. And 1 nonavalent vaccine is now available, which is active against 6, 11, 1, 18, 31, 33, 45, 52, and 58. So it is quite confusing. One is against 2, other is against 4, and then other is against 9. But even if you vaccinate with this 4 quadrivalent vaccine or a bivalent vaccine, that is more than enough. Remember this thing, because of the cross reactivity. The question with the vaccination comes of the cost, which is very important whenever we want to introduce this vaccination in our private practice or as general and the government policy. So let's see the cost. The cost of Cervarix, which is available in India, is around 2,600. The cost of the Gardasil is 3,100, and cost of Gardasil 9 is 10,000, right? But remember that, as Dr. Leela and Dr. Juchi said, now we have our own vaccine available from the Serum Institute, that is CERVICAL. And the cost of this is only 2,000 rupees, that also 2 doses. And for the government supply, it is much cheaper. Right? So we can all use in India the CERVICAL vaccine for efficiently vaccinating our young girls till the age of 26 years. So cost should not come. See, even if you have one pizza, it is costing 600 rupees. So if you get a family pizza, it is 1,000 rupees, 2,000. Why can't you get females vaccinated for that? Okay, so let's talk on what age group should be targeted first. So that is a very important component. And as I have shown you, the graph, the infection is most common between the age of 15 to 26 years. And if this infection becomes persistent, that causes a pre-invasive lesion. So it is better to target the girl who have been a sexually naive population. So it has been recommended by WHO, Government of India, Indian Association of Pediatrics, FOXY, American College of Pediatrics, that we should be vaccinating our young girl till the age of 15 years along with other vaccinations. And to end cervical cancer, 9 out of 10 girls should be vaccinated against human papilloma virus, right? And what should be the right age? Right age should be 9 to 14 years. Coming to the why we want, again, dealing some more on the target age group, why we want to deal with the young females less than 14 years. You see, most of the vaccination are being given until the adolescent age. Our vaccination strategy is almost complete till the age of 15 years. So the GMT antibodies induced by the vaccine are 2 times higher in girls when they have been vaccinated in less than 15 years as compared to 16 to 26 years. Vaccination of older females should be considered only if it is affordable, cost-effective, and does not divert the resources from vaccinating the primary target population. ACIP recommends the catch-up vaccination for all persons through age 26 years who are not adequately vaccinated. However, the decision to vaccinate adults older than 26 years should be made on an individual basis. Remember that if you are vaccinating, that doesn't mean that you will stop the screening. You should not be doing that. So screening should go hand by hand along with the vaccination to achieve this 90-70-90. Coming to the dosage schedule, what should be the dosage schedule for this vaccination? You see, this is a dream come true. And this statement from the sage WHO has come as a boon for all low middle income countries that 1 dose of HPV vaccine offers solid protection against cervical cancer. And remember that these are the studies which have been done in India, Africa, and many of the countries. And now we can, 1 dose efficiently protects against cervical cancer. So the patient who is not affordable, you can even give 1 vaccine. And what is the advantage of giving this? Because now you can vaccinate more girls and women. SAGE urges all countries to introduce HPV vaccine and prioritize multi-age cohort catch-up of missed and older cohort of girls. Single-dose schedule provides comparable efficacy of 2 or 3 dose regimen. So advantage that we can achieve our targets. It is less costly, less resource intensity, facilitates implementing catch-up campaigns, and allows financial and human resources to be directed against the other health problems. So now this is the latest recommendation regarding the WHO HPV vaccine strategy. That means between 9 to 14 years, you can have 1 or 2 dose schedule, no problem. Between 15 to 20 years, you can have 1 or 2 dose schedule. And more than 21 years, it is recommended to give 2-dose schedule, and the interval between the 2 doses should be 6 months. Even if you are missing at 6 months, you can give at 1 year also, and it has been demonstrated that it has got a good efficacy. But remember that if you are immunizing the immunocompromised patient, including HIV, they should be receiving 3 doses if feasible, if not at least 2 doses. And there is a limited evidence that you should be vaccinating with 1 dose in the immunocompromised female. Now, there are few queries which must be banging in your mind, which I'm going to take. Can you think of? No, absolutely no. There is no need of booster shots in case of HPV vaccination strategy. It gives very long protection. 10 years, 15 years trials which are available with us shows that there is a good antibody titer level is still persisting at the end of the 15 years. So there is no need of booster shots. How much safe is this vaccine? Are we going to have any serious events? So there are no serious events. Minor events have been reported as a pain at the vaccination site, tenderness, swelling, fever, headache, myalgia, and gastrointestinal symptoms. But you remember, millions of doses have been given, and it has been shown to be very less. Reported rate of anaphylactic reaction is 1.7 cases per million. So you can see this is a very safe vaccine. Are there any contraindications? So if somebody has an allergy to the components of it, like it has been made by the yeast, so hypersensitivity to yeast, yes, it should not be given. Persons with a latest allergy, and in case of an allergic reaction such as itching, rash, urticaria, blisters occurring on the post-HPV vaccination, further doses should not be given. And avoid vaccination in girls with severe febrile illness. When she gets okay, only then you should be vaccinating these young females. Now, can you co-administer with other vaccine? Yes, it is very much beneficial, and actually it will help us to cover this vaccination if we combine with our other pediatric vaccination, and it can be safely administered along with other age-specific vaccination. Vaccination in the special population like sexual assault. Sexual assault actually increases the risk of HPV infection, HIV infection. So it is recommended to vaccinate this female with the HPV infection, although the infection which has occurred is not going to be prevented, but this female is going to be protected against the other viruses. Women who are coming to you with an abnormal pap smear, positive HPV DNA testing, shall we go for administering HPV vaccine? So in these cases, HPV vaccination in women previously infected with HPV is safe and leads to high level of immune response evident by the presence of potentially neutralizing anti-HPV antibodies in cervicovaginal secretion. Protection against non-prevalent HPV titers included in vaccine is activated similar to that in HPV naive women. So you can vaccinate. There is no problem after proper counseling. Right? Few more question has been left. So pregnancy and lactation, so not recommended during pregnancy. However, if by chance you have vaccinated any pregnant female or during early pregnancy, it is not an indicated to terminate these pregnancies, not at all. Remember this thing. And if you have given 1 doses, you have planned for 2 doses, you can vaccinate her once she delivers, right? Now, immunocompromised women, I have already covered that we should be vaccinating this female and we should be using 3 doses of this vaccine. Male vaccination, a very important component, because we are not stressing on the male vaccination as our target is to first vaccinate the females who are the most sufferer. But many countries like Australia, Canada, Austria, UK are vaccinating their males because they have completed the vaccination and their vaccination strategy is very strong of coverage of the females. So they are vaccinating the men also, because it prevents against the anogenital warts. HPV is a cause of penile cancer only in the 7% of the cases, but as such, the transmission can be stopped by vaccinating the men also. But right now in India, it is not recommended. Vaccination with nonavalent or quadrivalent vaccine protects against anogenital warts, and as such, in these countries where it has been recommended to vaccinate 11 to 21-year boys, and can be given up to 26 years of age for the prevention of genital warts and anal cancer. Right? So one more point is there: we should be vaccinating the men who are having a sex with the men. It can be given up to 26 years of age. So to conclude, I can say that incorporation of HPV vaccination in the prevention of cervical cancer is the need of hour. Combining vaccination with screening will bring about the most rapid decline in the incidence of the cervical cancer. And I would like to call you all, let's join hand together against this cervical carcinoma dreaded disease, where each 2 minutes, if I have spoken for 20 minutes, at least 10 females have died. So we should be joining hand together, and we should be taking pledge that we are going to vaccinate our females. We are going to advise for a vaccination and the screening to have a catch-up vaccination and catch the disease, so can at least a part of this elimination strategy can be achieved by 2030, if not earlier, right? So thank you all for your patient hearing. Over to you, Dr. Nidhi.
Thank you, ma'am. Dr. Swati?
You can call Dr. Swati.
Am I audible now?
Yes, you are audible and very much seen.
Yeah.
Okay, so you can ask Dr. Suhail to just
Dr. Sohail, Dr. Sohail, are you there?
Yes.
Can you?
I'm really very sorry. My connection has gone, and
it happens.
Now, you have given me the responsibility to introduce our next speaker, and she is Dr. Swati Agarwal. So before I proceed to introduce her to this CME, I must pay my sincere homage to Hakim Abdul Hamid Saib, who was the founder and the chancellor of this university, whose ethos revolves around the dedication, sincerity, and intention to heal the pain and be the real Hamdard. The major contribution of this great visionary to the world of medicine and the science is the integration of various sciences with the sole intention of patient well-being. May his tribe grows exponentially. So taking his vision forward, inshallah, we will come with an integrated approach towards achievement of health and well-being, especially for prevention of cervical cancer through screening and counseling in February 4th, 2024 on World Cancer Day. Now I would like to invite Dr. Swati Agarwal, Professor of Department of OBG, Lady Hardinge Medical College and SSK Hospital, New Delhi. She is Joint Secretary to NARCHI, that is National Association of RCH of India, for the year 2022 to 24, and Chairperson of Association of Obstetrics and Gynaecology of Delhi, that is AOGD, for the year 2023 to 25. She has been awarded FOGSI Fellowship in Endoscopy in 19, and she is also awarded with the FOGSI Dr. Kamini Rao Orator 2018. And she has also been awarded gold medals for microbiology, ophthalmology, surgery, and university topper during her studies. You are most welcome, Dr. Swati, and she will enlighten us with WHO cervical carcinoma elimination strategy.
Thank you so much, ma'am, for the kind introduction. It is my proud privilege to be addressing such a learned audience here today. And I thank you, Dr. Aruna, ma'am, for inviting me. So I'll be briefing everybody about WHO cervical cancer elimination strategy. But before I begin my presentation, I would like to convey my greetings from Lady Hardinge Medical College and invite you all for the upcoming NARCHICON 2023 from the 25th to 27th November. All of you are welcome. It is being held in the campus of LHMC. So moving on, if we look at the global estimates of the incidence of cervical cancer and the mortality related to cervical cancer, these are the statistics which were released in the year 2020 by the WHO. And you can see all the areas in the dark blue here, which, there is a marked difference in the in the incidence depending on the socio-economic status of a country. You see all the incidence is concentrated in the developing world, and even the mortality is correspondingly higher. But what is more disheartening to see is that while the incidence is 3 times higher in developing world as compared to the developed world, the mortality is 6 times higher. And we can see that our beloved India is also a part of it. Some hard facts. It is estimated that around 6 lakh cervical cancer cases are there globally, and 3.4 lakhs deaths, that is more than 50% of the people affected by it, die. This corresponds to an age standardized incidence of 13 cases per 100,000 women years, and a mortality which is just unacceptable. So, keeping this in mind, WHO launched the Global Cervical Cancer Elimination Initiative in the year 2020, and their target was to achieve a target of 4 cases per 100,000 women years, not just in the developed world, because in some of the developed countries, the incidence is as low as 2 per 100,000 women years. And as you can see, Dr. Aruna mentioned in her talk that Australia is claiming that it has eliminated cervical cancer. So this international disparity which is existing associated with this disease, the WHO aimed to eliminate that disparity. And Dr. Aruna already talked about the targets by 2030, the 90-70-90 initiative to vaccinate 90% of eligible girls against HPV. Eligible means less than 15 years of age. Screen 70% of eligible women, it is said, at once by the age of 35 and twice by the age of 45, and to effectively treat 90% of those with a positive screening test or a cervical lesion, including palliative care when needed. So in order to achieve these targets, it's very easy to set goals, but what is important is how we achieve these goals, and WHO has paved the way for that too. It has come up with revised guidelines for screening and treatment of cervical precancer lesions for cervical cancer prevention in the very next year, which gives us a comprehensive guide as to how to screen and treat the cervical precancer lesions. You will notice that there is a lot of leverage given to the countries. The guidelines are not so strict as they used to be, screening every 3 years, starting at 21 years. So all those guidelines have, undergone a major change just to ensure that, everybody does the screening uniformly. So we all know, and the WHO accepts that there are basically 3 approaches to cervical cancer screening. We have the molecular test, which include the nucleic acid amplification test, where we look for the high-risk HPV DNA, or more recently, what is coming up is HPV mRNA testing. We also, the upcoming ones is detection of certain oncoproteins and HPV antibodies. We all are aware of the cytological approach, which is by conventional pap smear or liquid-based cytology. Now, the other recent addition is staining with P16 and Ki67 to improve the sensitivity of the cytological testing. Visual inspection, either with naked eye or under magnification by a colposcope after application of acetic acid or Lugol's iodine, is another such strategy, which will be dealt in detail later on. And there have been now development of many commercially available automated machine which can do a digital evaluation of the images obtained and give you the interpretation. So AI is fast taking over all the job done by humans and with much more accuracy. So the WHO also defines what should be the approaches. We all know that there are basically two approaches towards screening and treatment. The first approach is the screen and treat approach, where the decision to treat is based on positive primary screening test only. Now, what is the disadvantage? The disadvantage would be that there'll be a certain amount of overtreatment, but this approach is very, very useful for a country like ours, where the loss to follow-up rate is very, very high. The other approach is screen, triage, and treat approach, where the decision to treat is based on a positive primary screening test, followed by a positive second test, which is the triage test, with or without histologically confirmed diagnosis. So if you're doing screen, triage, and treat, doesn't mean that a histological diagnosis is necessary, but yes, whatever the findings are, they need to be reinforced or by a second test. So this makes it more specific. But WHO says, and there are many studies which says that if when you look at the cost analysis and everything, both the approaches are comparable. So whichever approach is suitable to your setup, you may choose that approach. Now, what should be the primary screening test? That is the big question. I've told you about the 3 screening approaches. What should be the primary test? The WHO recommends using HPV DNA detection as the primary screening test rather than VIA or cytology. As of now, we were doing pap smear, that is the conventional. Even VIA in developing countries was an acceptable test, but now there is a growing body of evidence that HPV DNA is the way to go forward, and not just in general population, also in women living with HIV. A question will arise, HPV DNA detection, expensive test, not available in the government setup. How is it that we are going to switch over? WHO just makes a recommendation, but the WHO also says that existing programs with quality assured cytology as the primary screening test should be continued until HPV DNA testing is operational. But those using VIA as the primary screening test should transition rapidly because of the inherent challenges with quality assurances. So they have given us a leverage, but the future lies with detection of HPV DNA as the primary screening test. Now, which approach to choose? Screen and treat or screen, triage, and treat? WHO says that using HPV DNA primary screening test either with triage or without triage should be used among general population of women. That is, you can choose any of the screening or screen and treat modalities or the approaches depending on the resources and whatever is feasible for you. But yes, it also says that for women living with HIV, the approach should be with triage rather than without triage. Now, what can be the triage modalities? Following a primary positive HPV DNA testing, it can either be a partial genotyping. Partial genotyping means testing for only HPV 16 and 18, because as Dr. Aruna said, 70% of all cervical cancers are associated with these genotypes. So that can be done. Colposcopy can be done. VIA can be done, and even cytology can be done to triage these women. So these are the 4 options which can be used as the triage modalities. How to collect HPV DNA sample? Should it be collected by a clinician or should it be collected by the woman herself by self-sampling? So the WHO says either of the samples are good enough. When to start screening? Now, this is very, very important. As I'm saying, just to improve the coverage, the focus is now to start the screening at a later age, because the incidence of cervical cancer, as cervical cancer has got a long latent period, the incidence is very, very low, below 25 years of age. So WHO recommends starting regular cervical screening at the age of 30 years among the general population, and a little early, that is 25 years, for women living with HIV, because immunosuppressed women, we all know, are at a higher risk of cervical cancer, not only acquisition of the HPV vaccine, but progression to cervical cancer is also faster in these women because of immunosuppression. So the age to start screening is 30 years in the general population, 25 years in women living with HIV. How frequently to screen these women? WHO says a screening interval of every 5 to 10 years when using HPV DNA detection in the general population. As expected, the screening population is, the frequency is lower. It's every 3 to 5 years. The frequency is, it's more frequent when it comes to women living with HIV because the progression is higher in these women. However, if you're not using primary HPV DNA and are using cytology or VIA as a screening modality, then of course WHO recommends that you should screen every 3 years. Now, when to stop screening? The traditional teaching was that we should screen till the age of 65, but now WHO says that the screening can safely be stopped at the age of 50 years after 2 consecutive negative screening results consistent with the recommended regular screening intervals are achieved among both the general population of women and women living with HIV. Now, there are certain questions which still remain. What if a woman is screened positive on HPV DNA, but you do a triage test and she's negative on a triage? Then how do you go about managing her? So the WHO says that for general population, if she's positive on HPV DNA, negative on triage, repeat HPV DNA testing after 2 years. And if negative, go to the regular screening interval. And this retesting interval is a little shorter in women with HIV. It is retesting at 12 months. And if negative, move to the recommended regular screening interval. Well, how to screen, how to follow up the treated women after screening? Suppose a woman has come positive for CIN1 or sorry, not 1, 2 or 3. CIN1 we usually leave for monitoring, and usually we do not treat CIN1s. So what to do if the patient was, CIN2 and 3 and she has been treated by, say, thermoablation or large loop excision or whatever method? How to screen these women? WHO suggests that these women should be retested at 12 months with HPV DNA testing. That is the preferred modality. And if it's negative, then you move to the recommended regular screening interval. However, in an HIV positive woman, you retest this woman at 12 months. If she's negative, retest her again after another 12 months, and only twice if she's negative, then she moves to the regular screening interval. Now, if you have limited resources and you were to prioritize which women should be given priority for screening, WHO says that priority should be given to screening women aged 30 to 49 years in the general population and 25 to 49 years in women living with HIV. But here it's a rider that, if you have a woman who has never been screened in her life, then of course she should be given priority. And if tools are available to manage these women, and then, of course, the elder women, that is 50 to 65 years of age, should also be prioritized. Now, when to initiate treatment after screening? Of course, the answer is pretty obvious. The treatment should be immediate or within 6 months. Why is this question important? Is that, in circumstances where treatment is not provided within this time frame, it is a good practice to reevaluate the woman before treatment, because it is likely that the lesion might have progressed, and what was amenable to an ablative therapy earlier would now be a candidate for an excisional therapy. Also, in women who are pregnant, it is a good practice to defer the treatment until after pregnancy. I'm not going to go into the details of what kind of treatment, because it is going to be covered later on, the eligibility criteria for ablative method. So I'm just going to mention a word about HPV vaccination, although it's been covered in quite a detail by Dr. Aruna. But why was the reason to come up with a revised guidelines for HPV vaccination? Because it was noted that between the year 2019 and 2021, coverage of the first dose of HPV vaccination actually fell by 25% to 15%. So that means 3.5 more girls missed out on HPV in 2021 compared to 2019. So there was a need to come up with strategies that were more comprehensive, more easily acceptable, which would increase the compliance. So this slide, which has been previously shown, but is a very, very relevant slide. Initially, we used to say 2 doses of HPV vaccine before 15 years of age and 3 doses after 15 years of age. But now the WHO says that a single dose is good enough till 20 years of age, and it is only after 21 years of age that you need to give 2 doses. However, a point here is that all these studies have been done on the vaccines which are already available, that is the Cervarix and the Gardasil. The recently introduced Cervavac vaccine, that is the Indian vaccine, recommends 2 doses. So, and that has actually not been studied in detail whether the 2 doses would, whether a single dose would be efficacious or not. Most likely it will be, but just to say that there are no studies available on the Indian vaccine. But for all the other vaccines, till 20 years, you can safely give a single dose without the need of any booster dose. So just a few take-home messages before I wrap up my presentation. The WHO call for elimination of cervical cancer gives us a target of 90-70-90 by the year 2030 and aims to reduce the number of cervical cancer cases to 4 per 100,000 women years in every country. And what they recommend in the general population is screening with HPV DNA in a screen and treat approach or screen, tried and treat approach, starting at the age of 30 years with regular screening every 5 to 10 years. For the women living with HIV, HPV DNA detection in a screen, tried and treat approach only, starting at the age of 25 years with regular screening every 3 to 5 years. And after the age of 50 years, screening is stopped after 2 consecutive negative screening results in both general population as well as women living with HIV. For HPV vaccination, the WHO recommends 1 or 2 dose schedule for girls ages 9 to 14 years, as well as for women aged 15 to 20 years, and 2 doses with a 6 months interval for women older than 21 years. So I thank you all for a patient hearing. Don't let cervical cancer stop you. Get vaccinated, get screened, and it's time to end cervical cancer. I thank you all again for a very patient hearing.
Hello. Thank you, Dr. Swati. Dr. Ziba, can you introduce please our next speaker?
Thank you, Dr. Nidhi, for giving me this opportunity. We have a very young, energetic Department of OBG who seems to be very, very educative around. Cervical cancer screening, very relevant. Molecular and cytology plays an important role. And we have Professor Mamta Dagar, who's be talking about pap smear and HPV DNA testing. Professor Dagar is a senior consultant. She's at Gangaram Hospital. Besides being associated with and affiliated with many other committees, she is trained for gynae endoscopy at Kiel, Germany, besides having a robotic surgery training from Paris. She's member of the Royal College of OBGs, besides having many other fellowships. Professor Dagar, I'd like to give you the stage to please start your topic.
Thank you, Dr. Ziba. Yeah, thanks for a very kind introduction, and thank you, Dr. Aruna, for the invitation. So basically, I shall be speaking on the topic that is PAPs and HPV DNA testing. And initially, in fact, I thought that I have very less to talk on this topic, which is in fact the cornerstone of any screening program or cervical cancer screening. But later on, I realized that there is so much of information to be given on this basic aspect. And I hope I'm able to do justice with the topic which is allotted to me. So I proceed with a little background, which has already been talked about, that it was in 2018 that call to action on elimination of cervical cancer was taken by the Director General of WHO, Dr. Tedros Adhanom. And it was on 17th November 2020, exactly 3 years back, that there was a launch of the global strategy to accelerate the elimination of cervical cancer. We know that we want to see a world without cervical cancer by 2030, wherein we want to see a prevalence of less than 4 per lakh women. And of course, this is attainable, as Dr. Aruna has said, by vaccinating 90% of the girls less than 15 years of age with HPV vaccine, and by screening 70% of the women at 35 to 45 years of age with a high precision test. And of course, this is to be followed by treatment of 90% of precancerous lesions, which will be talked about by the subsequent speakers, Dr. Arifa and Dr. Arifa, I think. So we all know Dr. Swati has said that WHO has laid down guidelines for screening and treatment of cervical precancer lesions and cervical cancer prevention. And we have our own FOXY GCPR, good clinical practice recommendations for prevention and management of cervical cancer, which were published in 2018, and in April 2023, there was a revised version. This is just again a recap of probably what has been talked, and we know that the FOXY has laid down these screening recommendations that we want to screen these women, and they have basically advocated the primary HPV, high-risk HPV testing every 5 to 10 years of age. In limited resource settings, at least twice in a lifetime of 35 to 45 years, or if it is not feasible, by cytology every 3 years, or even the VIA every 3 to 5 years. VIA and villi as the screening methods will be discussed by Nidhi, I understand. So, and Dr. Swati has very beautifully explained that the screen and treatment approaches by WHO, whether it is a screen and treatment approach or it is a screen, triage and treat approach, the cornerstone is that we need to do the screening and by a screening test. So there are 3 clinical scenarios in the routine screening programs which are employed, that either we are doing a regular screening at regular screening intervals, in which we are following guidelines, which applies to women who had either had a negative screening results or have completed the recommended additional follow-up after treatment, and who are thus eligible to return to regular screening intervals. Or else we are following up women who had a positive primary screening test but a negative triage test. Those women who have undergone treatment of CIN, we are following these women after treatment. So everywhere we are employing screening tests. The 3 approaches to cervical cancer screening, and there are future tests. Dr. Swati has said the molecular test, which employ the nucleic acid amplification test or NAT technology, which use HPV DNA, NAIT, and mRNA test. These are the current tests. Why there are future tests such as DNA, methylation, and protein biomarkers, which are the tests which are still under evaluation. Then amongst the cytologic test, which is the age-old, of course, not to forget the traditional, almost 8 decades old conventional Pap smear. Then came the liquid-based cytology, which is the current test, which is being replaced by Pap smear in most of the institute and facilities. And of course, there is a role of dual staining to identify P16 and K167. And there are visual inspection tests, that is VIA and villi, which Dr. Nidhi will be talking. So the cervical cancer screening, whatever screening test which are using, whether the cervical Pap smear, cytology, or HPV, they identify a pre-existing pre-invasive cervical lesion. The Pap smear or cytology has been the mainstay of cervical cancer screening for the past 60 to 80 years. However, there is an increasing awareness about the limitation of cytology because of the interpretation, which is subjective, because of the potential sources of error, because the lesions are either not sampled or abnormal cells may not be transferred. Preservation of the cells may be inadequate, or there may be reading errors. So it has been found that the single PAPS test has been found to have a low sensitivity in the best of the centers, not more than 65, in fact, less than 70%, somewhere between 40 to 69%. And also it has a poor positive predictive value, and it requires at least 3 years repetition as a screening test. So the key clinical question is that has informed change is the reduction in the burden of CIN3 and cervical cancer incidence and mortality by the combination of high-risk HPV and combined with cytology with 60 to 70% greater efficacy than cytology alone. Not to forget this cervical cancer screening test, the sensitivity and specificity, which all we shall be knowing, that the cytology has a sensitivity of not more than 70%. And however, it has a good specificity, which is more than 90%, up to 96, 97%, while the HPV DNA test has a good sensitivity as compared to cytology, which is somewhere between 90 to 95%. However, it has a specificity of less than 90%, meaning thereby that the false negatives will be more with the cytology and the false positive will be more with the HPV DNA test. And visual inspection of acetic acid stands somewhere between the cytology and HPV DNA, as you see, in terms of sensitivity and specificity. So largely our screening programs have been based on cytology, but they need an established lab, trained and reliable cytotechnologist, and repeated visits. For that matter, HPV DNA came, basically they found that the HPV DNA have a good sensitivity, but the cost is an issue, and they only tell regarding the HPV inspection. And of course, visual inspection of visual methods, they are the most cost effective and very good for community screening, and the results is immediate. So going back to the PAPS first, a little background, which is my topic. The conventional Pap smear has been the most successful screening test. It was the George Papanicolaou, the great scientist, who reported in 1928 the PAPS test as a routine cervical screening test for cervix uteri, which was reported in 1928, and its efficacy was proven in 1941. So it is now almost more than 70 years, almost 80 years old. So it was found that only this cytology, where there has been intense cervical screening programs, this screening every 3 to 5 years has resulted in a 70% decline in incidence of cervical cancer. Then came the concept of liquid-based cytology in 1970, and it was in 1987 that a National Health Service cervical screening program in UK was launched, and they found that it has been successful in decreasing the incidence and mortality of cervical cancer and has led to 80% prevention of cervical cancer. So why came the liquid-based cytology, which has been introduced, is that there has been a continuing improvement in the cervical cancer screening program. They identified the limitations of conventional cytology, and with modernization of technique and all, they found that the future benefits of liquid-based cytology was, besides the extra test, which is the HPV, which is now considered as the test of choice for cervical cancer screening by WHO also. The other advantage is that it also basically tells you about other infections like chlamydia, neisseria, gonorrhea, and all. So what does this liquid-based cytology means? It means the cytology or the study of cells through a liquid medium. And why it basically came into repute was the certain advantages which got identified with liquid-based cytology, that it simplifies the collection process for the smear taken. It reduced the inadequacy of the rates. The cells are better preserved and not obscured by blood, mucus, or inflammatory cells. The infectious organisms are retained and better preserved. It is quicker to screen and report. Multiple slides can be produced, allowing further testing. The residual material in the vial can be made available for the further test, that is the HPV test. And it facilitates computer assisting screening, which can be available in future, which is called the automated cytology. So, as I said, not to forget, still there are, in India, I mean, there are places where there is no facility for liquid-based cytology or even the HPV. So we definitely, to attain this target of 70% of the screening women getting screened by 2030, not to forget our traditional old age pap smear, which is the technique of removing the cells from the surface of the cervix. We basically, though this is not the diagram for a pap smear typical, the cytology, but basically we are looking for those exfoliated dead cells which are being removed from ectocervix and endocervix. And we are basically obtaining a scraping with a wooden spatula and smearing them on the glass side and staining and examining them microscopically. So the idea is to focus the sampling to obtain adequacy of the squamocolumnar junction, which are examined under the microscope. So how do we perform this, the pap smear or the cytology, or if we are also combining the HPV or taking HPV, is that, of course, it is not to be done during menstrual cycle, though there is no set time, but yeah, during heavy menses, it is not suggested to basically taken. But yeah, even with the light bleeding spotting, it could be taken. Yeah, because it is an opportunistic screening. You need to insert a speculum into the patient's vagina to allow the access to the uterine cervix, and then samples are collected from the uterine cervix opening or os of the cervix using an IS spatula when we are taking a conventional PAPs, or if you are using an endocervical brush or a plastic fronded broom device when we are taking liquid-based cytology. So basically what is the essence is that we need a examination table and a light source. Of course, it has to be an informed decision, and you need to do a prior counseling that you are offering a screening test for cervical cancer screening to the woman, which takes few minutes before you are undergoing this. So this depending on your facilities and all feasibility and all, the examination table could be this, which could be put in dorsolathottomy position with the slight, the stirrups kind, and the light source could be the halogen or the LED light source, or even the woman may lie in the dorsolathottomy position on a flat surface, and you can have a portable light source. The thing is that you need not have a very elaborative kind of a setup. It depends and varies from facility to facilities, and very modifiable depending on the facilities which you are having. So what are the consumables when you are doing the PAPS test or LBC or HPV testing? You need a sterile cover tray, which is containing the following instruments. Of course, sterile self-staining vaginal speculum of different sizes. Disposable specula can also be used. And these following consumables are required for the sample collection, that is gloves, then brush for cervical sample collection, the tubes containing specimen transport medium, the lubricant jelly, which is to be avoided if the sample is also used for cytology, the printed labels or a pen to write on the specimen tubes and lab requisition forms. And in addition to the equipment and the consumables, the screening forms and registers are needed for documentation of the identity number, name, date of the sample collection, etc. And some clinics may also have a computerized system of record keeping. The whole idea is it should be documented and recorded. So these are the various sampling devices. Traditional, we were using wooden IR spatula. All of us, when we were the undergraduates, this is how we started our cervical cancer screening. Then came this plastic IR spatula, and also came then various devices such as endocervical brush or a cotton swab. Then came these Cervarix or broom kind of a devices or cytoprep instruments. So the whole idea of all these is to basically do the cervical sampling basically, or the cervical cancer screening. So everything came with an advancement with its pros and cons, because it was realized that with the traditional wooden IR spatula is not doing justice, maybe in terms of cell yields, and certain cells with the wooden spatula got mixed. So which was found that they're better when the plastic spatula is used, because the cells are less adherent to the plastic and there is more cell yield. Then endocervical brush and the cotton swabs were found to be better in terms of endocervical sampling. Then came the broom, because it was found that a combination of ectocervical sampling and the endocervical sampling if you put on a smear, then gives an adequate smear, and you basically have to have a device which samples both the ectocervical cells and the endocervical cells. So basically, these are the advancements which keep on coming with various sampling devices. So if we basically are taking a pap smear, this is the traditional pap smear. Once we take it, it has to be basically placed on a thin slide, and it has to be thin and properly labeled. And when we are taking a pap smear, just make sure, I shall be, of course, showing a video of how to take a liquid-based cytology, but the principle is the same. In case of pap smear, this long end is there, which is basically goes inside the endocervix, while the short end, which appears blunt, basically rests on the ectocervix, and it is rotated then 2 to 3 times around the cervix very gently. It is not like that you do it clockwise or anti-clockwise. The whole idea is to apply a gentle pressure, not to cause bleeding and pain to the woman. And then take the sample, which is taken, and immediately put on a slide in one corner, because on other side there's a label, and then it is to be put in a fixative. Now, what this fixative is, that it is an agent which is used to prepare the cytological specimens for the purpose of preserving and maintaining the existing form and structure of all constituent elements. And mostly the fixatives are a combination of ethers and 95% ethanol in the ratio of 1:1. However, there may be 95% ethanol, 95% rectified spirit, 100% methanol, 80% isopropanol or propanol and all, which could be used as a fixatives. If you are using the spray fixatives, it contains the isopropanol and propylene glycol. So this is how the spray fixation is being done. That in the spray fixation of the smear, the optimal distance between the nozzle and the slide is approximately 10 inches, which is 30 centimeter. And why? Because if we are using the distance which is too less, then it is going to probably damage the cells, and it is, if the distance is more, probably your cells are going to dry. This is what the probably the logic behind is, and the explanation, the scientific explanation of this distance, which is the optimal distance of 30 centimeters. So as I said, we have now moved on to the better devices, sampling devices, and are into the era of liquid-based cytology and HPV. And we are looking for a sampling device which is basically going to do the dual purpose of taking both the LBC and HPV. The labs have devised various sampling devices, and these are various broom devices or the cytobrush. If you look at this device, these are the bristles which are basically taking the cells of the ectocervix, and while this is like a endocervical brush, this device. So this ectocervix and 0.5 centimeters of endocervix is sampled with this device. This device also, the principles are the same. They are more or less plastic, blunt kind of a bristles, and very malleable. And the sampling device is rotated around 360 degree in clockwise and anti-clockwise direction, maintaining a gentle pressure. So we basically are using SurePrep here in our institute, and this is a very short video by the BD SurePrep.
The Rover cervix brush is designed
to take
to
liquid-based
deliver cell
cytology,
yield by
as well as
sweeping
HPV.
the ectocervix and reaching well beyond the transformation zone into the cervical canal. The bristles of the brush are flat on one side and rounded on the other to provide a gentle scraping edge when rotated clockwise. Because the bristles are flexible and conform to the patient's cervix, you can get a good sample of the mucosal surface without damage. This device can be used with most patient populations, including pre- and postmenopausal women. Collecting a sample for a BD SurePath liquid-based pap test using the Rover cervix brush is easy. Insert the extended bristles on the tip of the Rover cervix brush into the endocervical canal. The extended bristles will stiffen and penetrate the cervical os. Gently push the brush into the cervix until the lateral brush bristles splay out over the ectocervix. Maintain gentle pressure and rotate the brush 5 times clockwise by rolling the shaft between your thumb and forefinger. The flat edge of the brush gently scrapes the cells from the cervix. Rotating the brush 5 times ensures the brush has collected a good endocervical sample. Once the sample has been collected, send the entire brush head to the lab using the new BD SurePath collection vial. Hold the collection vial firmly down on a flat surface and then insert the brush head into the larger opening, rotate the brush 1/4 turn, and then use the inner edge of the insert to pull off the brush head right into the vial.
So this is how the liquid-based cytology is being obtained. So basically, whether you are using a thin prep or you are using the SurePath for liquid-based cytology, this brush is removed and deposited in cases of thin prep in the methanol-based liquid medium, while in cases of SurePath, the ethanol-based liquid medium. And the RBCs which are sticking to the brush are lysed by the transport medium. This is the main benefit. And they do not obscure with the reporting. So a little word about this transport medium, which these tubes are containing, and the specimen transport medium. The selection of this transport medium, it depends on the recommendation of the test manufacturers and whether the same specimen will be used for cytology triage. The specimen for the hybrid capture 2 or care HPV test can be collected in an aqueous buffered collected medium, such as Digene specimen transport medium or Quagen, while a specimen collected in specimen transport medium cannot be used for cytology, which may be required for triage of HPV positive women. So the specimen for all HPV tests can be collected in a methanol-based collection medium, such as Preserve Cytec and Roche collection medium, or in an ethanol-based collection medium such as SurePath. And such media, they preserve the cellular integrity so that the specimen can be used for both HPV testing and liquid-based cytology. However, the amount of liquid in the tube varies from 1 ml for the Digene specimen transport medium and to 20 ml for the Preserve Cyte or the Roche medium. We all know that once these samples are processed and they're sent to the laboratory, it is the great role of our cytopathologists to report them, and of course, due credit to them for reporting. And this is the Bethesda system for reporting of pap smear, which is being employed, the latest Bethesda system, which basically looks for epithelial cell abnormalities and glandular cell abnormalities. And this is how the pap smear is reported, the cytology is reported in terms of NILM, SCUS, SH, LCIL, HCIL, and squamous cell carcinoma, the epithelial cell abnormalities, while the glandular cell abnormalities, if there are any, they are expressed as atypical glandular cells of endocervical, endometrial, or not otherwise specified, or atypical glandular cell favoring neoplasia, adenocarcinoma in situ, or endometrial cells in women more than 40 years of age, or adenocarcinoma in others. So moving further, we know to the HPV, because this talk will not complete till I touch on the HPV and finish with the HPV, that human papillomavirus is the major etiological agent of cervical precancer and cancer. We all know by now. And there are two major factors which are associated with the development of high-grade CIN and cervical cancer, which are the subtype of high-risk HPV and the persistence of the virus. We all know that it is a non-enveloped double-stranded circular DNA virus, of which more than 100 types have been reported, of which 40 infects the genital tract. There are the non-oncogenic or the low-risk types, 6 and 11 are the common ones, which cause almost 90% of the genital warts. And amongst the oncogenic high-risk types, which are almost 15, HPV 16 and 18 are responsible for 70% of the cervical cancer. The credit to the discovery of HPV as a causative as an agent of cervical cancer, of course, goes to Dr. Harold Hussein, who basically in 1976 hypothesized that the HPV plays an important role in causing cervical cancer, but he was awarded Nobel Prize in 2008 for his discovery and was recognized for his work. And structure is, as I said, it is a small non-enveloped icosahedral DNA virus, which is double-stranded with 72 pentameric capsomeres and has two structural proteins, late 1 and late 2, which are both virally encoded. It has a role in the pathogenesis of cervical cancer. this infection is limited to the basal cells of stratified epithelium. This virus cannot bind to live tissues, and it infects first the epithelial tissues through microabrasions or other epithelial trauma which expose segment of the basement membrane. And this HPV virion associate with receptors such as alpha integrin, laminins, and annexin A2. And then they cause cancer through the mediation of these proteins, early proteins, which are A6, E7 proteins, which inactivate the two suppressor proteins, P57, which inactivates the E7, while retinoblastoma, which is inactivated by E7. So basically, E7 acts as the primary transforming protein. E7 competes for retinoblastoma protein binding, freeing the transcription factor E2F to transactivate its targets, thus pushing the cell cycle forward, while E6 in association with the host E6 associated proteins, which has the ubiquitin ligase activity, acts to P53, leading to proteasomal degradation. And this is how it causes cervical cancer. In a nutshell, basically, that if there is apoptosis induction, there is elimination, while there is, when it is blocked P53 degradation, then there is an outgrowth of deregulated cells. Dr. Aruna has already basically probably has shown this sort of a diagram that what is the natural history of HPV infection, that it's nice 2 decades are formed from infection of a normal cervix with HPV to the development of precancerous and cancerous lesions of the cervix. And because normally in more than 90% it is cleared by 3 years due to the basically immune response of the cells. However, in less than 10% of the cases, in another 10 to 15 years, it may progress to the development of high-grade lesion or invasive carcinoma, which is mediated by various modifiers and oncoproteins and all, which are sexually transmitted infections, HIV, smoking, immunosuppressed states and all. So coming down to the HPV tests, which are of 2 types, and those that report pooled high-risk HPV types, and those that report the presence of HPV 16 and 18. So HPV, basically, when we are detecting, it can be detected via the DNA testing, RNA testing, and testing of cellular markers of HPV, as I have talked a bit earlier also. And these specimens for HPV testing can be obtained using a swab, broom, brush, or tampon, which is then placed in a transport media. And there have been almost over 100 tests which are available worldwide, but they're not comparable. So basically, we are essentially looking for a test which can be of validated test. So this is a validated HPV test list, which is basically being given by POXI in our POXI guidelines as well. These HPV tests employ the molecular test, employ the nucleic acid amplification techniques. So which could be either the signal amplification techniques, which are being used by the hybrid capture 2 by Quagen, Cervista, HPV HR test, or care HPV test, which is the point of care test. While there are other HPV tests which use the PCR based test, which are the COBAs.
Dr. Mamta, I think, has disconnected.
Okay. Dr. Pratibha, kindly ring Dr. Mamta. In the meantime, I think she's totally... we will take 2-3 questions. They are there in the question answer, which I have already answered. And we'll see that in next 15-30 seconds she joins or not. Okay. Till that, I'll take few of the questions. So one have asked, ma'am, Dr. Arpita, please take 2-3 questions from this question answers area. Unmute yourself.
Yes. So we have one
Hello.
question from Ms. Shabana. If a female with warts is on high risk of HPV, can she conceive? What are the effects on the male partner? So this is related to what's related to HPV. So related to HPV, warts and conceiving, if I can, Dr. Nidhi, do you want to take that question? Am I audible?
Yeah, you are audible. Kindly continue.
So this is the question related to HPV warts and conception. And what is the effect on the male partner?
Okay, so which question you are taking? What are the causes and sources of HPV infection?
No, ma'am. There is the last one, which is female with warts is on high risk of HPV. Can she conceive? So basically, warts, can she conceive? That is the question. And what is the effect of warts on male partner? This is what has been the one of the questions.
Okay, okay, she can conceive, there is no problem, but the problem occurs during the time of the delivery because this can be transmitted to a baby during vaginal delivery. So it is better to tell her not to conceive and get her first treated for the same. Regarding the male partner, because it is being caused by the HPV 6 and 11, so always it is a sexually transmitted disease, so it can be transmitted to males also. There is no hope, but we need to be careful, and the female should be, male partner should be using a condoms during the time of treatment. Okay, so I think Dr. Mamta has joined back. Please continue, Dr. Mamta. This slide has already been taken care of. Shown. Next slide.
So
this was also taken. Next slide, Vidya.
So care test is also one of the other very few. So anyway, though HPV DNA testing in our setup is not yet a part of any national screening program, but we are doing opportunistic screening, and we know that in our country cost is a concern. We also have self-sampling, which is available. It is available, the kits are available, which are being provided by Roche, and studies are going on. And these self-sampling has overcome the cultural and logistic barriers towards screening the hard-to-reach women. And there are still very validated tests which are being available. So this is a whole list of HPV tests which are available in the Indian market, ranging from 1400 to almost 2200. I think I cannot finish my presentation till I basically talk about the HPV self-sampling, which is now proven to be effective and acceptable
requesting
method
Dr.
of
Mamta
cervical
to kindly wind off in the next 5 minutes, please.
Just 2 minutes. Yeah.
Okay, thank you.
Within 2 minutes, I'm fine. Yeah. So it is the WHO now has laid down the recommendations on the self-care interventions. And I said that the HPV self-sampling is a part of cervical cancer screening and treatment. So there is an update. There is a very good, this thing which is available on the WHO site. HPV self-sampling said will improve screening for cervical cancers. And this can now really is the way forward which can contribute to the eliminating cervical cancer as a public health problem by 2030, because it is found to be easy, painless, convenient, cheap, and woman maintains the privacy. You handle the HPV self-sampling kits to the woman, and then the healthcare workers can collect and then process it in the laboratory. It's very easy to collect. It is what the Roche is providing are the flow-Q swabs, which are just a very gentle earbud kinds of the vaginal swabs, wherein you can just put the swab into the vagina, and this swab or brush is inserted into the vagina gently and rotated almost 10 to 30 seconds, and this swab or brush is removed and transferred to a provided collection tube, and the shaft of the swab or the brush is broken off and discarded, and then sample is sent to the laboratory by the healthcare worker, clinic, and through the postal services, and the results are also provided. So basically, sticking to our resources, sticking to our screening recommendations, What the Foxy suggests is you check the available resources, logistics, and finances for cervical cancer screening, and basically employ the test which is acceptable, affordable, and sustainable. Whatever you are doing, PAPS, LBC, or HPV, if it is a good resource settings, preferred is that do the primary HPV testing every 5 years in the age group of 30 to 65, while what is acceptable is do the cytology every 3 years from 25 to 65 years and via every 3 to 5 years. While in the low resource settings, there is a role of affordable HPV test wherever it is available, and there is a role of via. So, of course, let's stick to the this WHO call for eliminating cervical cancer and accelerate our efforts to attain a cervical cancer-free future. Thank you. Thank you for the patient hearing, and sorry for the disturbance.
Okay, so I think we will move to the next lecture. So Dr. Nidhi, do you want to put on the slide?
My slide visible?
Yes, it is about to come. Yes. So Dr. Nidhi, she is associate professor here, and she has been in charge of the oncology specialty clinic in this hospital. She has special interest in adolescent gynae preventive oncology with multiple publications, multiple medals, including gold medal in AOGD, Best Editor Award, etc. And she has, so I invite her to the dais to proceed with the next topic. Thank you.
Thank you so much, Dr. Arpita, for the nice introduction. So we will be discussing now the visual methods for the cervical cancer screening. This has been, introduction about the cervical cancer has been given by so many speakers that it is the most common cancer, and it is a, death due to the cervical cancer has decreased over the few years because of the screening. And screening in this cancer is possible because this cancer is caused by a high-risk HPV infection, that is a viral infection, and this is having a long pre-cancerous stage. So, is this cancer preventable? Yes. So, screening can reduce both the incidence and mortality in this cancer. These are the various methods for the screening. Other methods like cytological and HPV testing has already been discussed by Dr. Mamta, and we will be discussing the visual methods. Visual methods can be unaided. That means we just visualize the cervix with the help of a cusco-speculum, or aided. That means we will do the visual inspection after application of acetic acid. This is the full form of VIA. This was also the question in the chat box. What is the full form of VIA? Okay, am I audible? Okay, so after VIA, if we do after application of acetic acid, if we see under magnification, it will visual inspection along with the magnification. And after acetic acid, we can also apply Lugol's iodine. That means visual inspection with Lugol's iodine. So these are the visual methods for the screening of cervical cancer. Before going to the visual method, this is an important zone which I want to tell. That is a transformation zone, because all game or jitni bhi gadbad honi hai, wo sab isi zone mein hoti hai. The pink one is the outer one, that is the ectocervix, and the red one is the endocervix. The joint, the line, the crest and the trough, which is shown by an arrow, this border is the transformation zone. So when we are applying acetic acid, or when we are looking the cervix with the naked eye, we have to see specifically this area. Okay. Now coming to the next slide. That is, first is unaided direct visual inspection. This method of screening is also very important, because it decreases around 30% reduction in both the chances, that is the incidence, as well as of the invasive cancer, as well as the cervical cancer mortality. In this, we use a cusco-speculum, and the normal cervix will seem like this. It is shown with the arrow also that both the fornices, and the pink is the ectocervix and red is the endocervix. After this, come to the aided. That means when we apply something along with the visual inspection. These three terminology I have already explained. Coming to them one by one. So first is visual inspection by acetic acid, that is VIA. This is the tray in which we are needing the substances which for the VIA. So there are the swabs for application of acetic acid, and there is the acetic acid, then the cusco-speculum. After this, coming to the procedure. The lithotomy or the dorsal position can be used for the patient. We will insert the cusco-speculum as shown, and the cervix should be visualized completely as it is shown in the diagram. After this, we will apply 3 to 5% of the acetic acid to the cervix liberally, and we will wait for 1 minute. The acetic acid should be freshly prepared. After 1 minute, we will go for the result interpretation. What are the interpretation? But before going to the interpretation, actually what this acetic acid do? This acetic acid makes the proteins coagulate, which make them white. So the cells who are immature or who are having abnormal cells, they are having high protein content. So the acetic acid will coagulate these proteins to make this area white, so that it can be stand out. This is the basic principle behind the application of acetic acid. So these are the interpretation. When we see the first diagram, the arrow shows the transformation zone. But as we can see, this is via negative. There are no acetovite areas, or there can be a faint acetovite area which disappears on its own. Coming to the second diagram, as you can see, there are multiple irregular projections seen on the cervix. These are the suspicious of cancer. So when there is an ulcerative growth or ulcer with acetovite areas, this is a very much suspicion of cancer. Now coming to the via positive. Via positive means, as you can see, there are raised white areas seen around the cervical opening, that is in the transformation zone. These 4 diagrams, all of you can see, this area is the via positive area. In the second diagram, whole of the transformation zone is showing the acetovite areas. So when sharp, distinct, well-defined, densely opaque or oyster white areas appear on the cervix after the application of acetic acids, ring the alarm. Sensitivity and specificity, or I would say the performance of VIA has already been discussed by Dr. Mamta, that it is having a very good specificity, and sensitivity is also comparable with the PAPs. I will say a little bit higher. There are various studies which have shown the VIA performance. The recent study is in 2022. So what are the advantages? VIA, it is simple, easy to learn, can be performed at a rural areas because it is a cost-effective one. We are not needing much instruments for this VIA. I have already shown you the tray. Requires only 1 visit. If we found any abnormal area, then treatment, that is screen and treat. It can be given at the same time. And after VIA, for a confirmation of the findings, we can also do a villi, that is the application of Lugol's iodine. So these are the advantages of VIA, that it is a low resource setting. It can be a very good screening method. Okay. Now, after the strength, what are the limitations? I would not say disadvantages. It will be the limitation of this method. So firstly, it will be a rater dependent. So any person who is doing VIA at a rural or the peripheral center, they should be versed enough that what is an acetovite area, which woman is to be treated and which woman is to be referred. There are high chances of having false positives that may increase the overload to the referral systems. So this may be the limitation. And there's one more limitation, that in the post-menopausal woman, in which that transformation zone has already gone into the endocervix, it will be less accurate in those cases. So this is VIA. After this, when we apply acetic acid, we can also visualize the cervix with the help of a low power magnification scope. It gives us around 2.5 to 4x magnification. So that if there any small acetovite area which can be missed on a naked eye, it can be seen with the help of a magnification. Otherwise, the sensitivity and specificity are similar. These microscopic or magnification systems are portable. They can be used in the rural areas also. After this, coming to the villi, that is visual inspection with Lugol's iodine. So it is done when we have done the application of acetic acid and we have found a normal area. So then we apply a Lugol's iodine over it. What is the principle behind applying the iodine? Lugol's iodine has an affinity for glycogen, that it is a glycophilic. So whatever cell is containing the glycogen, villi or the iodine will stain it. So squamous cells which are there on the ectocervix, they are rich in glycogen, and the columnar cells which are on the endocervix, they are having no glycogen. Similarly, the immature cells were partially glycogenated, and the precancerous or the cancerous cells, they are not having any glycogen. So, अब हमें पता चल गया है which cells are having glycogen and which are not. So the cells which are having glycogen, they will take up the color of the iodine, And the cells who are not having glycogen will not take up any iodine or any color. These are the few images shown for the villi. The first image, as you can see, around the mahogany brown color. These are the cells, squamous cells of the ectocervix, who are rich in the glycogen and they have taken the iodine very well. The first image you all can see. And in the middle is the endocervix area. They are the columnar cells which are not having any glycogen and they have not taken the iodine stain. And this area, you can see between the mahogany brown and the pink color is the transformation zone. This zone is also healthy. There are no area of any discoloration or any iodine not uptake. Now coming to the second image, as you can see, mahogany brown area and the endocervical area. But in the mahogany brown area, you can see this is an area which has not taken the iodine stain. This is an area of abnormality in a transformation zone. So this area we need to be considered. We need to be seen. Coming to the third image, we can see that all of this is ulcerative growth which has not taken the color. So this is a suspicious of cancer. So this is about the villi. These are the few images I have put to ask, but I think we are getting short of time. So this is a normal cervix. You can see there are no acetovite areas. Ecto and endocervix is very well seen, and this is your transformation zone. After this is the acetovite area, you can see. And third one is a suspicious of cancer. You can see anterior lip, there is a growth, ulcerative growth. Okay, thank you. This is all about via and villi.
So I think this was a very nice lecture by Dr. Nidhi, and the images were also very excellent. And now that you have explained how to identify the precancerous lesion, I think we can move on to our next speaker. She would be talking about the management of these precancerous lesions, and the speaker is Dr. Arifa Anwar. She is a professor and unit head at HIMSR, and she has special interest in infertility and minimally invasive surgery, and she is also a member of the multidisciplinary committee of the AUGD. Now over to Dr. Arifa for her topic.
Before Dr. Arifa take over, let me say one announcement that the certificates can be downloaded after 72 hours. Information for the same will come on your mail. So you can download it after 3 days once information comes to your mailbox. So keep checking your mailbox for the certificates. Thank you. Dr. Arifa, over to you. Kindly unmute yourself.
Yeah, good afternoon, everyone. Am I audible? Am I audible?
Yes, you are very much audible, madam.
Okay, so after listening so much to the screening, I think by now we are all very clear about how important it is to screen, and then only one can prevent the cervical cancer. So coming to the after screening, we have two modalities of management, that is screen and treat approach and screen, triage and treat approach, which has been dealt very clearly by Dr. Swati also. But in screen and treat approach, we have VIA and HPV DNA. These are the two primary tests which are available. VIA is a test which is a very good test in terms of low middle income countries where it is very cost effective test. So it can be done in a mass patients, and HPV DNA, which is a test for good resource country where if it is positive, if it is negative, one is assured that one can extend the screening from 5 to 10 years. And coming to screen, triage and treat management, here one has to screen with cytology and take you have so many tests for screening in terms of cytology, HPV DNA, and then you triage either with colposcopy or high risk HPV DNA or by VIA, and then treating the patient. So here one has to treat the patient only once screen and triage both are positive. But in screen and treat approach, it is a single visit approach where patient will be treated simultaneously after the screening. This will help in better compliance of the patient. It will reduce the cost, and it will also sometimes over treats the patient. So to conclude, all high grade lesions including CIN 2 or 3, they all should be treated. Low grade CIN 1, one has to review either after an year, or if you treat the patient if you feel that the patient has a poor compliance. Now, the principle behind the treatment is that you should be able to see the whole transformation zone, and it should be treated completely. The minimum depth of treatment is 7 millimeter, and you have to also do the surveillance of the treated patients to assess whether the patient has got cured or there is any kind of persistence of any lesion there. So coming to the treatment modality, there are two types of treatment modalities. Either it is an ablative treatment modality or an excisional one. For all of you, I think you should be knowing and very clear about the ablative method, which is cryoablation or a thermoablation. This is actually destroying the abnormal tissue either by heating it with thermal coagulation, which is called as thermal ablation or thermal coagulation, or by freezing it with freezing it, that is called as cryotherapy. And if one has to do the excision, then it is called as LEAP. That means you excise the abnormal area, abnormal transformation zone. Or there is using the energy source as laser, it is laser excision. And using the knife, it is called as cold knife excision. Prerequisites of ablative treatment. So what we need to be sure of when we are taking the patient for ablation. So there should be type 1 transformation zone. The lesion should be located entirely on the ectocervix, and there is no endocervical canal or vaginal wall in vaginal involvement of the lesion. Lesion should be entirely visible, and it should occupy only not more than two quadrant of the cervix. If it is like occupying more than 2 quadrant, then it's better to go on the excisional method. There should be no suspicious of invasive malignancy, invasive carcinoma, and it should be covered by largest size cryoprobe which is available. One can take the biopsy before before doing the cryo treatment if the facility for biopsy is available. Now, what are the contraindications? If patient is having postcoital bleeding or a woman with postmenopausal bleeding, not a good choice. Or if there is an obvious cervical growth, irregular surface, cervix bleeds on touch, and in pregnancy, it is better to wait for a while before doing the cryotherapy if the patient is on a good follow-up. It is a safe procedure. And how does it work? It works by crystallizing the intracellular water. Now, a gas is used which crystallizes the cell and evaporates the water. The temperature to the core of the ice ball is minus 89, and to the edge it is minus 20. So it is basically freezed using nitrous or carbon dioxide. So it is actually freeze, thaw, and freeze cycle, which is around for 3, 5, and 3. And then what instrumentation you use is that you need an examination table, you need a good light source, speculum. Condom is required so that the vaginal wall doesn't fall over the cervix, and you should not be burning that vaginal wall. Acetic acid, saline, and sponge holder, and the swab sticks, and of course the cryoprobe, nitrous cylinder. So now this is the cylinder, and these are the cryoprobes. You see, one is a conical shape and the other one is a blunt one. So if it is a wider area, one can use a blunt one, and if it is special near the os, then one can use a conical one. This is a typical cryosurgical unit which is attached to the cylinder either using carbon dioxide or nitrous. So the temperature is little different at the probe tip if you are using carbon dioxide, and if it is nitrous, it is minus 89. So it is basically destroyed it is actually freezed, and this is destroyed. The temperature at the probe edge is -20. This is how it looks like, in the first picture. This is how you need to apply the probe during the treatment, and the activated cryo probe on the transformation zone will, make it will extend a few millimeter beyond the edge of the cryo probe. And finally, a cold button is formed immediately after the cryosurgery. Coming to the thermal ablation, if the heat is used, it is destruction of the transformation zone or the abnormal area using heat, that is called as thermal ablation. It is also called as thermocoagulation or cold coagulation. The metallic probe is heated to 100 degrees Celsius and it is applied to the transformation zone for a period of 20 to 30 seconds. The epithelial and stromal destruction of the lesion happens, and then the patient is thereby treated. This is how the instruments look like. Now, after doing cryotherapy or an ablative therapy, you need to advise the patient that, you should not get worried. There might be a good amount of discharge for a period of 3 to 4 weeks. She should avoid intercourse for 4 to 6 weeks because she can bleed. She should not be using any kind of tampons and douche, and she should follow up after 3 months. She should also be advised that if there is any kind of fever, foul smelling discharge, bleeding, or lower abdominal pain, she should report back immediately. There are few early complications and few late complications. Like I mentioned before, that there is cramping, pain, or discharge. So these are early and intermediate complications. Late complication being cervical incompetence and cervical stenosis. Follow up, now this is very important. Once you have done the ablative procedure, you need to keep the patient on follow up at least 6 to 12 months follow up, and whatever facility you have in terms of doing a cytology or HPV DNA or via villi, or if facility for colpo is available, then one should follow these patients in all these different modalities of screening methods. If there is any abnormal area, again you find, then there is no role for repeat cryo or ablation. Then one has to take these patients for an excision and do the leap. If it is small quadrant less than 2, the cure rate is pretty high. It is 90 to 95%, though the recurrent is just 4 to 5%. If it is a small lesion and CIN2, again the success is nearing 95 and the recurrence is less than 10%. It is around 7%. But yes, if it is more 3 or more quadrants, the cure rate is 75% and recurrence is pretty high, around 17%. And it is preferred not to do this. Now, the success is when you select the proper selection of patient, you use correct cylinder for pressure, correct size probe, adequate time for application. There is a meta-analysis in 2019 which shows that difference between thermal coagulation and cryotherapy, and there is hardly any difference between the two. The aim is same, that you either burn, destroy, or remove the transformation zone of the cervix, and by freezing or by heat. Just a word about the newer device. This is Pop. It is actually a portable device which is simple and can be operated by any trained technician or a midwife. It is based on carbon dioxide, which is easily available, and it is in the solid state. So it is more effective than the gas when it is used in the gas-based system. The consumption is substantially less when compared to the conventional gas-based cryoprobes. Device doesn't require to be connected with the cylinder during the surgery. One can just take it. Is a very handy kind of an instrument, and it is under there is a lot of trials going on. There is absence of capillary tube eliminates possibility of blockage and subsequent servicing. A word about the excisional method, that is LEAP, which is large loop excision of the transformation zone, or loop electrosurgical excisional procedure. The both word are interchangeably used. One can also use the knife to do conization. And finally is the hysterectomy.
Now, finally, points to remember is that there is no need for prophylactic antibiotic. One can treat with cryotherapy if nothing is available. During pregnancy, don't do as I said if the patient is on good follow-up. Twice freeze is recommended, and screen positive after cryo, you have to treat with LEAP. Thank you for patient hearing.
Thank you, Dr. Arifa, for such a nice lecture. Dr. Arpita, can you please summarize the session for us, for all of us?
Or would you like to talk about the course first, Dr. Nidhi? Maybe I can then summarize.
Okay. So once again, I just want to share our course, which we have started in Hamdard Institute of Medical Sciences. That is the basic preventive cervical cancer screening course. It is recommended for all who are interested. And we will be dealing or will be telling all the skills, lectures. There will be lectures. There will be training on patients as well as on dummies, to how to take history, how to take screening methods, and including all which we have studied in the lectures today. This course is of 2 days duration, and after 2 days there will be assessment, that is the exit exam. At a time we will be accommodating 5 students, and for contact you can contact me. For the course you can contact me on phone as well as on mail ID. Both are written on the slide. You can copy it and contact me, mail me by any method. You can ask me about the course.
Okay, so
thank you.
Thank you, Dr. Nidhi. I think we all now can see that what all things will be covered. And since we are talking to you all, you're all healthcare professionals, you know, it is not only doctors, it is nurses, and it is you who are in direct contact with the patient or the woman in general. And for this, you have, if I have to summarize in 2 points, where you stand a role is to, number one, you have to re-emphasize about prevention, HPV vaccine for all. So I think we have talked multiple number of times, less than 14 years, minimum of all the doses, irrespective of, you know, if they can afford, it is 3 doses, of course, and WHO says even if they cannot afford, at least 1 dose should be given. And the second priority is screening for all. So when women come to you, whether they have problems, no problems, please push them for pap smear via villi. And in case any woman has any problem, refer to a gynecologist. These can be simply treated by thermal ablation, which are available in most of the tertiary care centers. It is available in many of the clinics as well. So here, I think the Ayush and the nursing people, they have to take this task upon themselves to spread the word and ensure that we are able to eliminate cancer cervix in the next 10 years. Now, I think as a thank you, I would like to thank all the speakers for simplifying this huge topic into a very simple thing, which is easy to understand, easy to take home and to follow. I would like to thank the chairpersons for sparing their time to be with us in these sessions and help and support in every manner possible. So thank you very much, all the delegates, speakers, chairpersons, and faculty. Aruna ma'am, over to you.
Once again, I like to announce that the certificates you can, after 3 days, that is 72 hours, the mail will come to you, and then you can download your certificates, which are being signed by myself, organizing secretary, and the ISCCP, that is Indian Society of Colposcopy and Cervical Pathology, in the association of which we have done the CME. And thank you all for joining and making this CME a success. All the chairpersons and the speakers, we are highly indebted to you for concise presentation and finishing in time. Thank you all. We can have one picture if all can switch on their cameras. Who is clicking the photograph? Myself?
I can take it. I'm waiting.
Just take it one.
Yeah. One more.
I'm thankful to all the delegates, especially who have joined in huge numbers.
Thank you, Dr. Arun.
Thank you, Dr. Sohail. Thank you, Dr. Mamta.
Thank you,
Thanks.
Aruna. It was really very nice and very
Yeah, very
effectively
nice.
done.
Very well thought of. Very
Thank you,
precise.
madam.
Thank you so much.
Thank you.
Thanks.
Thank you so much.